I would like to welcome everybody to today's webinar where we're going to talk about these new comprehensive primary care programs. We will be talking about both the Medicare or CMS CPC Plus and the Ohio Medicaid CPC programs that were recently announced. We're going to really try to cover as much information as possible within the hour. We're going to try to do a comparison of both programs. With that, I'm going to turn it over to my good friend and partner in crime, Miss Cathy Costello.
Hey everyone, welcome thank you for joining us and welcome. I will tell you right now before we get into the details, if you are not sitting there with your finance director or someone from your finance department, that is your first big error. So you email them right now and tell them to get on. This model is as much financial or more financial as it is clinical. It is really important that you have clinical, IT, and finance all involved in understanding the model because you're going to need a lot of financial backing and even to register. And before we get into the models, I just want to make one comment because this has been a commonly asked question since the announcements came out a couple weeks ago. For those of you who suffered through the MIPS proposed regulations with us a couple of months ago. We obviously are still waiting for the final regs, but the one question that has come up is, are these two models, CPC Plus and Medicaid CPC, do they constitute an advanced alternative payment model under MIPS? And what that means is, are you protected on your incentives, and do you have to do all the filing associated with MIPS? And it's my understanding from looking at the information that's been put out by CMS that either one of these programs would constitute an advanced alternative payment model, and the financial significance to your providers for that is they would automatically receive a 5% payment increase on their Medicare fee-for-service bills or claims for the following year. So it is a significant, and that's over and above all the other financial incentives that we will talk about. And we obviously will cover this in more detail when MIPS becomes final, but the place where it appears in the regs is that this would be considered a medical home model. And so this would have significance in a couple of ways. It would not be as risk-bearing as some of the other models, and that is really why Medicare or CMS created a kind of a risk-bearing, very small risk-bearing part to the model, was to fit it into those alternative payment models. So with that being said...
Now there is one very specific exception to the risk to being included as an APM. There was some language around the Medicare Shared Savings Program Track 1 that's also a CPC Plus may not be considered risk-bearing.
Right. Well, but
that's very, very specific.
Yeah, we'll have to see how that all fits together. So to be continued whenever CMS gets around to releasing those regs. But I just wanted to know, because I know a number of you had emailed us to see if we had any sense of that. And so it will be helpful to your financial people to keep that in mind, that people who participate in this would also receive the 5% incentive payment if they are participating. So let's go on and look at the details. And what we're going to do is, these are really two separate models. Despite the fact that the name is very similar, CPC Plus for Medicare and CPC for Medicaid, they really are different. Their clinical aspects are very close, and they both mimic patient-centered medical home models, PCMH, which is why you'll see PCMH talked about, especially under Medicaid. But the model is PCMH coupled with chronic care management and transitional care management. That'd be my thumbnail sketch of what the model looks like. But after that, you really diverge in how they're managed and how the finance runs. So we're going to try to talk about each program separately and point out every place where there's either a difference or where there's a significant point that you should know or you should be addressing before you register. Okay, we do have a list of acronyms, which there are many this go-round.
Yeah.
So if you're getting lost in the slides, go back and look at that as we move ahead. Okay, first we're going to talk about Medicare. And this was the overarching umbrella new payment model of which Medicaid flows at least part from that, and we'll look at that in the relationship when we get to Medicaid. Medicare is open for registration right now. Right now, from now until September 15th, and we'll talk about that registration process in the next few slides. But before we get there, let's look at who is eligible to participate under the Medicare program. Obviously not pediatricians. Due to their patient base, they are pretty much going to move straight into the Medicaid program. But also other groups that are not eligible are our rural friends, rural health clinics, and any FQHCs and concierge practices. The reason that rural health centers and FQHCs cannot participate is they operate under a different payment model. If you have providers who are part of your system but not billing under the rural health center, you can participate, because the biggest thing to note, and this is a very significant difference between Medicare and Medicaid, is that the whole Medicare process, the registration, the attestation, the financial side, all tracks back to the practice site and not to the TIN. So we all are used to that. If you're doing quality reporting or you're doing meaningful use or you're doing anything else that pertains to working with CMS, at this point in time, you are working under a TIN, whether it's an ACO TIN, a practice level TIN, an organizational TIN. Your tax ID number drives a lot of your relationships with CMS. Not so starting with CPC Plus, and this will have significant differences in how you prepare your registration information, because most of you, unless you're in an independent site, and some of you are, where your TIN, your tax ID number, drives that one practice site. In that case, you should not have any problem with your registration information. But for your larger organizations, this is going to create a problem, because most organizations do not function financially on allocation of all expenses and segregation of funds by practice site. They do it by organization. They may do it by practice community, you know, their ortho or their internal medicine or whatever, but very few do it by bricks and mortar practice sites. So this is going to be a significant difference. Please make sure your financial people are aware of this as you develop your information for that.
And the same goes for your informatics groups, your BI groups. You know, generally when you're doing your reports right now, if you're reporting via GPro, you're looking at a larger group, or you know, you're doing a lot of your quality reporting at the individual level. Start thinking about how you're going to need to restructure all of your reporting so that it's practice level. We're going to get into something called empanelment. You might have to do some empanelment level reports. So it's going to be somewhat of a shift.
Okay, so you do not have to be an independent practice. You can be a hospital-owned practice. You do not have to have every primary care practice site within a tax ID participating. But if you do participate, if more than one registers, you cross-reference those. But each registration is specific to one practice site. And what CMS defines as a practice site is, quote, bricks and mortar. So you may have a tax ID that covers 11 different practice sites, but each registration will be different for those 11 sites if they're all primary care based upon the bricks and mortar. And if you have a unified site for several different practice groups, which many of you do, we see this frequently, where you may have, say, 2, 3, 4 different practitioners, shared waiting room, shared behind the scenes, organizational pieces, billing, whatever. The common question here is, do they share the same patient load? Is their patient group the same? If it is, if it's a shared patient population, then you're okay to do one registration. If it's not a shared patient population and they just share space, then those are separate practice sites, even though they share a bricks and mortar address. So the other thing to keep in mind is, as far as prerequisites, you need to have 150 Medicare beneficiaries at that site that practice takes care of as a prerequisite for applying. You can be part of an ACO. You do not have to be. Another difference is with Medicare, that when you register for 5 years. And so if you're accepted, because it's not you registering and becoming part of it, it is CMS or Ohio Medicaid accepting your registration and making you part of the program. In the CMS Medicare program, you are expected to participate for 5 years. You can actually terminate early with 90 days notice, but they don't generally encourage that. They're looking for that overall commitment. Okay, here is the link for the registration, and we have provided for you the registration checklist for CMS, which is very detailed. It's one of the primary differences in Medicaid touts this, how simple their registration is compared to CMS's registration. And I would say that CMS's registration is extremely lengthy, lots of documentation required, and so you can apply for one or both, assuming you're eligible for both programs, and we'll look at the difference here when we get to Medicaid. You don't have to. You can be one or the other, but we'll show you where that overlap occurs if you apply for only one. For Medicare, you apply for a certain track, track 1 or track 2. Track 1 is more of a basic PCMH model. Track 2 is more of an enhanced model, and Scott will run you through the specifics on the clinical side a little bit later, but track 2 has more intensive work with the practices. With the patients.
And the inclusion of some behavioral health aspects as well.
Right, and you are not allowed to change tracks by CMS once you've been placed in one track or the other. If you apply for track 2 and they don't feel you're ready, they can place you in track 1, but they will talk to you about it. Another difference is if you are in track 2, you're going to need a separate IT support letter, and we will talk to you about that in just 1 minute when we get to the IT information. Here's the contact information that you have to have as part of the process. This is the first, obviously, your group name, your practice name, your IT contact person. And so they're asking basically for a clinical and administrative contact person for the organization. IT, they want all your primary care practitioners, full and part-time, and NPI, name, NPI, and specialty.
And they want those mid-levels, those advanced practice nurses that you have, they want those to be included as well.
Okay, then they want organizational information. So this is the name of your organization. If you're part of an ACO, the name of the ACO and the TIN. And just so you're aware of what CMS is thinking, they have 5,000 practices that are going to be brought in either under track 1 or track 2 in 14 states. Ohio's only one of the states that was accepted. Of those 5,000, 2,500 are track 1, 2,500 are track 2, and up to 1,500 in each of those tracks can be ACO affiliated. They don't have to be, but just so you understand that CMS is looking for practices that either have a commitment to doing some type of better patient management or are currently involved in a situation where they are doing that. They want to know, and this we think is a very significant issue because any of you who have worked with a practice are aware of it, and that is you need to list the name and TIN of anyone who practices at that organization, and if there was a different TIN used before this year, any TINs going back to January of 2013. So if you've changed TINs, if you created a new one, because a lot of you use different TINs for different parts of your billing, make sure you list all of those.
And those groups out there that have went through a lot of acquisitions might need to dust off some of the paperwork and get the old TINs as well.
Okay, and then you need to do % of your patients by race and preferred language. Okay, your meaningful use and IT part of the picture, you need to list. It's almost like doing an attestation without the metrics. So you have to list your vendor name, product, everything else.
Yeah, the function that you're going to rely on for the CPC Plus program from that vendor.
And you need to list the number of Medicare and Medicaid EPs you have, and how many of them have attested to stage 2 or are planning to attest to stage 2, and how many have currently attested. And then that last favorite part is your CMS EHR certification ID, which is the same certification number that you use for doing your meaningful use attestation.
It's one we commonly refer to as the chapel number, or
Right.
the chapel ID.
Right. Okay, as far as financial information, keep this in mind. This is why you want your finance person involved. This is practice level data. What is the revenue of that practice site in 2015? What was the revenue by payer? And what is the percentage of patient by insurance type?
And the reason they want this breakdown of information is, remember, this program now is going to include some of the private payers. They've been brought into the fold of the CPC Plus program.
Okay, they want to know about your care delivery structure. Are you a medical home already? Are you PCMH certified? And if you are, what level you are? Letters of support and commitment. These are biggie pieces of the pie. And so we're pointing this out to you to make sure that you get all the letters you need. You need a letter of commitment from your practice's clinical leader, not necessarily your leadership, organizational leadership if you're part of a larger group, not the CMO or anything like that. This is your practice. So it's a top person at that practice committing to the fact that you're going to do practice transformation. You also need, if you're part of a larger group, a letter from the system leadership / financial regarding the segregation of CPC Plus funds. This is where it gets very interesting for your finance people, because you not only have to report at a practice level, but you have to attest that you are going to segregate the funds related to this program, both the per member per month dollars and also any incentive dollars that are earned. It has to go back to that practice. So that is a totally different model than any of you have worked in before.
And for those that are currently in an ACO, you need a letter of support from your ACO, kind of saying the same thing, that they support the practice being in CPC Plus, and that funds that would that from the CPC Plus program will flow down to the practice level.
Right, but if you are in an ACO, your application is totally separate from the ACO.
Yep.
You have control of the practice site of participation in that. You do not either need ACO approval or to have other practice sites at the ACO participating. The third thing you need is Health IT cover letter. And this is only if you are in track 2. So if you're in that advanced track, you need a letter of support from your vendors. And I know as the HIE, we already have posted a letter with CMS stating what our capabilities are and that we would support you. So you can either, there's 2 ways you can get a letter. Go to the CMS website for CPC Plus, and they will list every vendor that has already sent a blanket letter of support saying that anyone who uses our EHR technology will receive our support. If your vendor is not in that list that has already submitted letters to CMS, then you will have to go directly to your EHR vendor and get that letter from them, because there are 2 functionalities in track 2 that are different. They're more like a stage 3 functionality that CMS is asking for. And one is that a care plan can be produced in that EHR system. And the other one is that there is psychosocial demographic information that is incorporated into that particular EHR system.
And these letters are not confined to only your EHR vendor, but instead all healthcare IT that you're going to use in support of your CPC Plus program. I will actually, to all the attendees on this call, we will send you a copy of the global letter that we filed with CMS so that you can reference that, because it kind of outlines the HIE and consulting services that we can provide that will supplement your EHR.
And the other thing to keep in mind is we are sending you the original documentation on the CPC Plus program that talks about what's expected of the vendors, and you can transmit that to your vendor if for some reason they are not familiar with it. Okay, let's move over to Medicaid, because I know we have a lot of people on the phone who are interested in the Medicaid program. Either they're standalone in the sense of pediatrics or rural health centers or FQHCs that might not be able to participate in Medicare, or they're just interested because they have a large Medicaid population. So as I said, keep these two programs separate in your mind, but we'll show you where the overlap is. Again, it's primary care driven, can be hospital owned or independent, can leave the program at any time, can be part of ACO, does not have to be. You do not have to re-enroll every year. The 2017 eligibility requirements. So Medicaid operates a little bit differently in this area than Medicaid. Medicare, once they draw together their practice sites for CPC Plus for Medicare, you are in, and nobody else comes in after that original 5,000 practices are accepted. Not so with Medicaid. With Medicaid, they're doing an advanced group in 2017 that are somewhat pilots for the program, but in 2018, the per member per month CPC model is opened up to any Medicaid practices that are eligible on the numbers. So the 3 ways that you can meet eligibility requirements for Medicaid in 2017, and keep in mind that Medicaid registration opens after Medicare. Medicare is right now through September 15th. Medicaid is October 1st through October 30th or 31st. So there's time for you to think this through, but whoever registers in October are the ones that are going to be considered for part of Medicaid. If you're registering for both, you need to do both. If you think your eligibility to participate in Medicaid is going to originate through Medicare, you still need to register separately under Medicaid. So the 3 prongs for Medicaid eligibility for next year is you have greater than 5,000 Medicaid members. Keep in mind, this Medicaid is by tax ID number and not by practice site. So again, kind of a confusing difference but basically when you analyze how many Medicaid members you have, you're looking at all the Medicaid people that your tax ID handles, whether or not they are at that particular practice site. So 5,000 Medicaid members in your TIN, and you have either some type of NCQA, PCMH accreditation. They do not specify levels, so you could be a level 1, level 2, level 3. Or you could have 500 Medicaid members and be accepted into the CPC Plus program for Medicare. If you are accepted into the CPC Plus program for Medicare, you will automatically receive an invitation to participate in the Medicaid program. Or the third way that you can establish eligibility is you can have more than 500 Medicaid members and be a level 3 PCMH accredited site. So if you're relying on the third avenue, you absolutely need to have that level 3 certification. So that may change from one site to the other within your organization. You just need to look at the eligibility. And as we said in 2018, everyone who's a Medicaid provider can be eligible. This is just a further breakdown of the Medicaid eligibility, but please note the biggest difference is FQHCs and rural health clinics. You absolutely can be part of this program even though you're not eligible for Medicare. Okay, the information for Medicaid registration is very simple, and we'll show you a screenshot of the registration page. As I said, I've heard them talk a few times, and they make a point of saying they have a one-page registration. So you're basically putting in your practice data, your contact information, and you check the attestation box to show that you're committing to share data that's necessary with the state and the payers. You're committing to being part of the learning community for practice transformation, and you're committing to meeting the startup activity requirements within 6 months. And as I said, you list your NCQA certification or whatever other certification you have for level 2 or level 3. And they will ask you if you have signed up to be part of CPC Plus, and if you've received any notice of acceptance. The Ohio Department of Medicaid website link is right here. You just click on Enroll Here. I will tell you right now that isn't live yet. It won't be live until October 1st, but here is the screenshot of what you're asked to attest to and enter. As we said, very short. Kudos to Medicaid for keeping it simple. And the nice thing about this big difference between the programs is Medicaid does not require any segregation of funds. So if you receive incentives, you receive per member per month, you can look at it at the organizational level and not the practice level. Dates for Medicaid, just be aware of this, is if you are eligible size-wise, and obviously Medicaid has a list of PCMH certification, they may send you an email directly to your organization or your practice site inviting you to participate in being part of a webinar about that. So if you are a large Medicaid provider, expect that email to come in the next week or two. They will host that webinar, as I said, on September 7th for those who've been invited to participate. October 1st will open their website for registration, and then they will announce all the people who've been approved. Later in 2016, they'll coordinate with CMS on what CMS is doing. And then the actual program for this group will start January 1st of 2017. Later, participants will be January 1st of 2018. Commercial payers who are also part, as Scott mentioned, they can be part of either the CPC Plus or the Ohio Medicaid. Here's the list of providers or payers in Ohio who are participating: Anthem, Aetna, AltCare, several of the Medicaid managed care, Buckeye, CareSource, Molina, Paramount, some of the other private payers, Gateway, MMO, the health plan that's out of Wheeling, as I recall, SumaCare, and United Healthcare. So quite a collection. But keep in mind that these are going to be separate registrations. Each one will have its own requirements. And so we'll just have to wait and see once everything dies down after the Medicare and Medicaid registration. We should have more information about this. But should you be accepted into either of these two programs, the private payers will have their own per member per month metric that they will invite you to participate in, and you can find out a little bit more. Whether that layers on a contract that you already have with that payer or whether it's a new model for you will have some bearing on how they handle your payments.
And you could see some variance in the foundational requirements. You could see some variance in the reporting requirements. We just don't know yet.
Yeah, and that's one of the big question marks. And you poor people who do quality reporting, between finance and quality, I can't think of who's holding their head shaking it more. But the quality reporting, we're hoping that there will be a closer alignment of the private commercial payers with the Medicare and Medicaid. But honestly, when it comes out, we'll look at that more carefully to see if they are identical to Medicare or Medicaid. Okay, financial models. We're going to run through this quickly, but just make you aware of where the differences are and the biggest areas. CPC Plus Medicare, as we said, has two tracks, and we'll talk about risk stratification in a minute. But in both tracks, the model is going to be a quarterly prospective per member per month fee that is paid to you to assist you in managing those patients. The amount of the per member per month depends on the risk stratification of the patients, and we'll talk about risk stratification in just a minute. Besides the per member per month fee, you will also receive prospectively. So at the beginning of 2017, if you're in the 2017 group, you will receive what we call a bonus payment. Think of this, it's similar to what you received in past years for PQRS bonuses, only CMS is paying it prospectively. And the reason they're doing that is they're making it risk-bearing, because of the two payments, should you not meet your quality thresholds, you will be at risk to lose the bonus payment, but not the per member per month. So per member per month is a lot larger payment than the bonus payment. The bonus payment can be a much smaller payment, but you're at risk for that. So they'll reconcile that at the end of the year to see whether you've met your quality metrics, whether you've met your cost metrics, and if so, you'll keep the full amount. If not, there will be some type of repayment of that. On the Ohio side, you have a per member per month, and I've seen this quoted in two different ways. One is a quarterly and one is a monthly payment, but I'm guessing it's going to be quarterly.
Yep.
And it's a per member per month, same as Medicare, different amounts, totally different amounts, and we'll look at that in a minute. But the bonus payment that Medicare pays prospectively, Medicaid pays the following year, similar to your normal PQRS modeling, where you file, and then if you're eligible for a bonus payment, they'll pay you. So that's the Medicaid model. The third source of revenue for Medicaid is a shared savings model. And this shared savings is only practices who have more than 5,000 Medicaid beneficiaries are the only ones who participate in the shared savings part. And there's a whole algorithm around that. We won't go into it, but just recognize there's 3 sources of payment from Medicaid per member per month, a retrospective bonus, small bonus, and then the third way is shared savings if you're large enough and you're eligible for it. Okay, Medicare financial model depends on the track. As we said, track 1's more of a basic PCMH look-alike. You do not have to be PCMH certified to participate in Medicare, but it's going to look like a Medicare PCMH track. In this one, when they say average, we're saying average because you'll see in a second there's all different risk groups that you can be in. But track 1 is a $15 average payment with a $250 per member bonus payment. And that's also paid prospectively. And then on top of that, for track 1, besides those 2 buckets of money, you also will continue to receive your fee-for-service payment. So you bill out your normal claims to CMS, and you would receive payment for that. And then on top of it, you receive your track 1 payment for per member per month management and for any bonus payment for your quality cost metrics. Now, track 2 is a little different, a little bit more complicated in what they're asking you to do, a lot different in the financial side. So the track 2, first of all, is a much higher average cost, but it can go up to $100 per month per certain members. And those certain members, I mean, you are being asked, this is not a giveaway, trust me.
Yep.
What you're seeing in track 2 is a much more sophisticated management of basically your highest need patients. And the ones that are placed into your top tier, and we will look at the tiering in 1 second, but I'm just pointing out to you what that would include. It's the top 10% of Medicare's risk stratification. So for all of those of you who suffered through with us in the past year and a half on QRUR reports, quality cost utilization reports, which we made you draw out of CMS, this is what we're talking about. Those risk stratification numbers is what CMS is applying to your patient panel. So you will know going in exactly who falls in which risk area. But if you're in the most needy group, the top 10%, which we all know are the ones that account for well over 50% of your costs within the system. So those top 10% plus any patients who have been diagnosed with dementia are the 2 categories that are going to show up in that top tier.
Now, remember when we said go get your finance guy or finance group, those care management fees have to be budgeted and expended at the practice level. CMS is going to ask for that budget. They want to see that those dollars, those care management dollars, are expended on expanded services outside of the normal face-to-face visit to take care of those patients to improve health and wellness.
And keep in mind, too, this, when we're talking about the 3 buckets where you get payment, not to mention the incentive payments under MIPS macro, but we won't get into that until we see a final reg on that. But the 3 buckets here, where you're per member per month, your bonus payment, and then what should be a fee-for-service model, under track 2, you are not a straight fee-for-service model. You still bill your claims out the same way that you would for Medicare Part B, but you contractually obligate yourself with CMS to meet a blended model where you're going to receive a reduced payment under your fee-for-service plus a managed care element. And the way that CMS explains that managed care is they are saying that although you're not going to be receiving care for every E&M visit the way that you normally would, they're saying it's your payment is going to be based on what your E&M visit that you normally get paid plus 10%. So it's supposed to be an increased payment at that level too, but don't keep in mind that Track 2 is being asked to do a lot of management of their most chronic patients.
Right, and that fee-for-service, that reduced fee-for-service, almost creates a fourth bucket, because what they're going to also ask you is up front, do you want to receive 35 to, what is it, 65% of your... I don't know if we covered that.
I don't know if we have that, but it's, yeah, there's two levels that you can agree to. One's a 40-60 split, and the other one's 35-65. So 35 to 40% would be the
CP. They're calling it the CPCP fund, and they actually will give you that money kind of upfront based on what they expect your fee-for-service charges to be at the end of the year. Then there's some reconciliation around that. But the reason they're doing that is to provide you with some more upfront dollars to get your programs off the ground, your care management activities off the ground a little sooner.
Yeah, and that's something you don't worry about at registration, because if you're accepted, CMS is going to be talking directly to your CFO to figure out what you're going to agree to on accepting payments. So don't worry about that, but just make your finance people aware that that's something they need to be thinking about and working on their model. The last thing I'd say on this page before we move on to how Medicaid pays is if you are in an ACO and participating in either in Medicare, you will not be eligible for that middle bucket, which is the bonus payment, because you will get your per member per month fee the same as everybody else. You will be part of any bonus under MIPS, but you will not be eligible for your performance-based incentive payment, that middle bucket, and that is a much smaller amount that you would receive prospectively from CMS at the beginning of each year. So ACO participants, you're basically getting that bucket replaced with your shared savings bonuses. Okay, here is how Medicare risk stratifies. And as I said, if you're familiar with your quality cost reports from CMS, QRURs, you're going to recognize this. It's the HCC categorization. And it's just that your payment, and you can actually go through and figure out exactly how much you'd get paid based upon how CMS risk stratifies, but it can run anywhere, and Track 1 from $6 to $30 per member per month, and Track 2 $9 to $100 per member per month. Track 1 is not responsible for that additional dementia or top 10% stratification. Medicaid does a little bit different. They do the per member per month upfront, as we said, quarterly payment, which is at roughly a $3 to $5 average. But it also is risk stratified, but that's just their average. As we said, if you're in a site that is, and they will pay you retrospectively for your bonus payment, if you meet the 3 things you need to meet to get that bonus, you have to show that you're working on or participating in all of the clinical improvement areas. You have to meet at least 50% of your quality metrics thresholds and 50% of your cost metric thresholds. If you do that, you will be receiving a bonus payment from Medicaid. The third area, and we had mentioned this, but it's worth saying it again, if you're a large group and you have over 5,000 Medicaid beneficiaries per TIN, not per practice site, per TIN, you are also on track to do a shared savings with Medicaid. That is a combination of your own internal improvement and how you rate against benchmarks. Okay, Medicaid has these 8 activity requirements that you can look through at your leisure, but let's just say they're PCMH. And considering Ohio is a very high PCMH state, I think all of you will recognize that. The efficiency measures are similar to, but not identical to, the Medicare ones that you see as part of QRUR. ED visits, readmission. This one has behavioral health split out as a separate area. In general, inpatient admission.
Yeah, and there's some wellness visits over time that are mixed in there as well. Now, also the 8 activity requirements, we're going to take a deeper dive into the function requirements under the Medicare program. And if you meet all of those function requirements, you're going to meet these activity requirements as well. And again, if you're a PC major, you're going to meet everything anyway, more than likely.
Yeah, and your clinical quality measures we're going to look at because they are different than CMS's. So we're going to do, here's the functional requirements, and then we'll end looking at the quality because it's important to know what the difference is in the quality reporting. Scott,
right.
Go ahead.
All right, and so there's really 5 functional areas. Think of these as your foundational clinical practice level functions or services that you have to have in place as part of this program. The increased availability, kind of the tagline under each of these functions, is really kind of how I kind of categorize these, or I view these different functions. But function 1 is access and continuity. I think of this really as increasing your practice availability. It's all around building trusting and continuous relationships over time. They really want you to expand your hours and develop alternatives to those traditional face-to-face visits so you can get folks, you can answer questions timely. You can see those patients in a timely manner. And really what you're going to be doing is constructing a means for the care team to be available outside of the normal hours to prevent those avoidable ED visits and admissions.
Yeah, and the way we have this set up is we think of this in terms of meaningful use, how you have a measure and then you have a way of measuring it. We did these back to back that way. Scott's talking you through the measure, and then the slide after each one of these functions is how they actually are tracking that.
Right, and so for function 1, access and continuity, here's the underlying requirements that you really got to meet. If you're a track 1, you have to impanel 95% of your patients to the practitioner, or really what we're looking at here is care team. This is team-based management, team-based care of the patient base. So empanelment is something that you probably think about or conceptually do, but they really want some actual empanelment to the care team. They want 24/7 access to the care team, and that care team have real-time access to the EHR. There's some other ways. We're going to see some probably relaxation or get some more information about really what those requirements are for 24/7 access. You got to organize care teams responsible for specific panels, and to optimize care continuity. That may mean, like, let's say you have a very large patient base with 1 or 2 providers. You may set up actually 3 or 4 care teams. Track 2, you've got to do everything Track 1 has to do. And then you really, what we're seeing as a focus here is providing services outside of the traditional face-to-face. Think of this as electronic visits, like a Skype type visit. If you have a high geriatric population that has trouble with transportation, maybe that means you're going to do home visits. You're going to do SNF-based visits, phone-based, just outside of what you're doing today in the office. This may also mean group visits. Think group nutritional counseling, diabetic counseling, just a lot of different things that fall under this category.
This is almost like a creative chronic care management program.
Absolutely.
You've heard us on chronic care management all year too, I know. But really think in terms of setting up chronic care management where you do phone visits, stuff like that. But this also includes home visits. It just depends on how you set up your program, how much staffing you have, and how you can reach the patient. But that's what they're saying, is create some alternative to seeing the patient in the office.
And think about that first bucket of dollars. That first bucket of dollars you're being provided is really to go towards this expansion of services. Now, there is a variance here with the Ohio CPC program. Ignore that plus after the Ohio CPC. They specifically call out same-day appointments under this activity. Now, our second function, they call it care management. I really call this building deeper relationships. What you're going to do is you're going to risk stratify your patient. You're going to look at your high-risk patients, and that's going to be the focus. That's where you spend most of your dollars. So not to say you're not going to focus as well on those lower risk, but you're really going to manage those high-risk patients.
Yeah, and just to clarify the risk stratification, because I know this has been just a point of huge concern and confusion, is even though both Medicare and Medicaid ask for risk stratification capability, what we have found out is both Medicare and Medicaid originally risk stratify your lists for you, whether it's Medicaid managed care or Medicaid, they use the same model, the 3M model, or whether you're using the HCC model for Medicare. All that will be provided to you. You have to show the capability of working with those, to split that down and actually develop your plans.
Yeah. And another thing that you really want to do, again, this functions all around that relationship with the care team, is that they really want you to identify those triggers that may take somebody of low risk and move them into a high risk category. Maybe it's they're transitioning to a new setting. Maybe they've just found out they have a new major illness that just kind of popped up that kicks them for a temporary period into high risk. Now, the underlying requirements, you've got to risk stratify all impaneled patients. Again, new concept to think about this empanelment. Then you got to provide, number 2 really says, focus your efforts on those high-risk patients. The third, under track 1, the third item is it really says make your transitional care management a priority. Get those patients in the office after they've been seen in the ED or discharged.
Okay, what does that sound like? How about transitional care management? Again, that's something CMS started 2+ years ago, and they're really intent on having everyone work with patients as they come out of the hospital or the ED.
So 3, 4, and 5, think transitional care management, think relationships with the hospitals that your patients tend to go to for ED care or even inpatient care as well. Track 2 focuses on, of course, everything under track 1, but they're adding the risk stratification. They really want you to dig into into your patient panel. They want you to risk stratify. They want you to take the risk stratification that you're given and really look at your local level and maybe do even a second level of risk stratification, based on actual clinical data, see how that all comes out, and then they allow some modification of the risk stratification based on your relationship with the patient. So let's say you run all your risk stratification and you see Jane Doe as has been stratified very low risk, but she's really high, so you can bump her up. That's really what that's saying. And then we jump down to number 6 under track 2. Really what they're talking about here is developing a patient action plan, a patient action-oriented plan of care for the patient's specific chronic conditions. And then you use that as a tool with all interaction with that patient between those traditional face-to-face visits.
Right. So for the difference here, and this goes back again to chronic care management, you need to have a care plan, needs to be in place, and you need to have the patient engaged with their own self-management.
All right, now with function 3, comprehensiveness and coordination, now we're expanding breadth. We're adding a little bit of depth. We kind of did that earlier, but really we're focusing on expanding the breadth of the services that the practice provides. Where you're going to develop some agreements or at least maybe some partnerships with other groups. They really want you to focus on the behavioral and health-related social needs. And really, again, the goal here is to lower overall utilization and really embrace the patient-centered medical home concept. Be the hub of all the services that your patient needs to improve wellness. And that means engaging your local community, your social services, your faith-based organizations.
Okay, and this one, note, this is where you track 2 people and need to have your vendor involved, because look at number 5 here, where you're doing an assessment of psychosocial needs and you're producing a care plan based upon that. So just make sure that's why you're looking for increased functionality.
And so you're seeing here they really want you to identify where your patients are going, identify the hospitals and the EDs, and find a means to improve timeliness of getting notifications around those patients. You know, and I'm going to do a shameless CliniSync HIE plug right here. That's Notify. You think of our Notify services that many of you have heard about. You will know when your patient's seen in not only the ED, you know, the hospital system that you may or may not be associated with, but hospitals across the state. Track 2, again, everything Track 1 has to do. And you'll see here that they want you to take it a step further. Not only do they want you to know where your patients are going, but they want you to enter into collaborative agreements with at least 2 groups. And again, that's the 4, at least 2 groups. They want you to then implement at least one option for integrating behavioral health care right into your practice level. They talk about psychosocial needs using evidence-based tools. You'll see that again and again the concept of evidence-based tools. They want you to conduct an inventory of those local resources and support agencies and build that referral network. Really what they're saying is evaluate the needs of your high-risk patients, the services you provide within your practice, and close the gap between what they need and what you have. Expand those services. All right, with 4, function 4.
This is a totally new area.
Yeah.
It's not PCMH driven. I mean, it is PCMH model, but totally new requirement here.
Right, and really, again, they call it patient and caregiver engagement. I called it patient family feedback. What you're really doing is you are going to establish a patient and family advisory council, and you're going to pull that group together. You're going to have a nice open discussion, a nice open forum, get their feedback, see how the patient thinks that care can be improved, find out what programs really, we think we know what works with the patient. They're going to tell us what really works. And they want you to take that feedback and integrate it right into your practice. If you're Track 1, they're saying get your advisory council together at least one time. Take those recommendations, put them into the practice. And also they want you to really expand the support that you have for the patient self-management plan. So it's not just give them a self-management plan, be on your way, and we'll talk about it next time I see you. You've got to build up that support mechanism. Really, this is patient engagement on steroids is really what we're talking here. Track 2, they want you to get the advisory council together a little bit more, and then they want you to really focus on self-management supports for the 3 high-risk conditions that are most prevalent within your practice. Now, function 5, they call it planned care and population health. I call it team-based population management. We sat in on one of these open door forums where they had a physician who was in the CPCI, which is kind of where this program grew out of. And the physician shared that his experience as a primary care provider, he saw his role really change to be a team leader. He was still providing primary care, but he was really leading the team that supplemented that face-to-face visit that the provider did. So, you're going to see this within your practice. It's very, very team-focused. They want you to organize your care and all of your services around your entire population. But let's be honest, you're going to have that extra eye on those high-risk patients. Again, they want you to improve population health, the health of your population using evidence-based tools. We see this again and again. Then really the last point here is they want you to run your CQM reports, and they want you to use those CQM reports, your QRUR reports, and other reports that you may create both at the practice and panel level to improve your the services that you're providing. And really with we look at Track 1 here. Track 1 essentially says the QRUR report, or whatever they're going to call the report, it's going to look like the QRUR.
Yeah,
let's
quarterly.
face it.
Track 1's quarterly.
Yep.
Track 2 is weekly. They want you to look at your information weekly, and that's the basic difference between the 2 tracks here.
Yep.
Okay, we're just going to very briefly brush on the quality metrics because you all will be digging down a lot over the next few months on these. But basically the difference is Medicare has, both for Track 1 and Track 2, are going to be required to report 9 ECQMs. I don't know if this is going to drop back when MIPS drops the number of reportable CQMs next year, but for right now, this is requiring 9 CQMs. And you pick, there's 3 groups, pick 2 out of the first group, depression remission, our favorite, controlling high blood pressure, and A1C poor control.
In primary care, you guys have seen these again and again and again.
Group 2 is high-risk meds in the elderly, dementia, cognitive assessment, screening for future falls, and engagement of alcohol and drug dependence treatment. So you pick 2 of these, so 2 out of the first, 2 out of the second. Here's the third, closing referral loop, some of your preventive screens, cervical cancer, colorectal, diabetes eye exam, tobacco screening, imaging studies for low back pain, and breast cancer screening. So a lot of preventive care. In this one, you need to pick out of the combined 1, 2, and 3, besides the 2 in the first and 2 in the second, you pick 5 of any of the remaining measures and report on those. Medicaid has a very established set of metrics here. There are 4 to the pediatric, 5 to the women's, 7 adult, and 4 behavioral health. Obviously, not all the metrics will necessarily apply to your practice, but those that do, you will not necessarily be reporting on it. Medicaid says they're going to be claims-based measures, but we honestly have to get a better handle of that as the program develops.
Yeah, we suspect there's going to be in the Medicaid program a few that you may need to attest to, but if you did pay close attention to the Medicare side, those are ECQMs at the practice level.
Comes out of your EHR system.
Right.
Whereas Medicaid, you don't even need an EHR system to participate. Don't ask me why. Don't get me started. But the reality is that Medicaid's like, well, if you can't report it, we'll do it out of claims. So we'll see how that all shakes out overall. But just so you know the measures that they're looking at. And these are, they said they may modify them a bit as the program gets up and rolling, but that's where they're starting.
Yeah, and we may see the addition of some additional measures under the Medicare side as well. So now we're going to talk about monitoring, auditing, termination. We're going to go through this real quick. What is monitoring? Well, CMS and some of their contractors, they're going to look at your reports. They're going to, think about your QR reports. They're actually going to look at them. If you're in track 2, they're going to step it up. They're actually going to do it some more levels of monitoring. The reason they're doing monitoring is there is the chance you could be placed on a corrective action plan. What that means is you either are not meeting the requirements, they think you're gaming the system, or your quality is not where it needs to be. They will put you on a corrective action plan.
6 months.
Yeah, it's 6 months to kind of right the ship. If you don't right the ship, you can be terminated. If they do place you under a CAP, they will inform the private payers that you've been placed under a CAP for the Medicaid or Medicare program. There's going to be audits. Right now, I don't know what the audit, they haven't really talked about the audit protocol.
We hope it's not bigliosi, but who knows?
Right. So, I do a lot of, Cathy and I both do a lot of work around audits. What I'm going to tell you right now is the documentation related to your budgeting, the addition of new services, quality reports, anything you purchase as in the way of software or licensing or services, keep that documentation.
Yeah, and you have to, please. One thing that we've seen is financial audits separate from clinical audits. And the financial audits, you have to show the segregation of funds. I would stress that more than anything else. If you purchase something as a result of that per member per month or the bonus payment or the shared savings, you have to show that it's being used for this program. So that's a difficult threshold for a lot of you.
And once they do release this, the kind of the audit protocol, and we know a little bit more about it, I'll do a separate webinar on it. Cathy and I will put something together and really give you some stronger recommendations on what to retain for your book of evidence.
Okay, so with that, let's see what questions we have. Thank you for hanging in there. I know we're running a little bit over, but you can see there's a lot of information here.
All right, question 1 is a practice that offers only behavioral health and not primary care services eligible to participate under either plan?
We do not believe so. We think that you absolutely need a behavioral health component if you're doing track 2 or some agreement with a behavioral health provider. But if you're strictly behavioral health with no primary care, I think this is a primary care initiative.
All right, this one, Kathy, is going to be a fun one to answer. My large group practice has one tax ID number. One department, that being family medicine, of the group is applying for CPC Plus. With MIPS, does everyone in the 10 qualify for the 5% bonus if application is accepted?
I guess part of that would be, what are your other business strategies? Are you part of an ACO? Are you part of any other advanced payment model? And right now, anyway, the way that MIPS is written, it's a combination of a TIN provider. And so I would say no, it would probably only be your advanced people or the ones who are part of the CPC Plus model. But the reality is your other providers could also be eligible for bonuses through MIPS, which may equal to or be greater than the MIPS or the 5%. The difference is the 5% is a given. If your model is there, under MIPS, you have to earn it. You have to present more documentation and stuff.
Next question. Is this Medicare fee-for-service only, or can it be managed care Medicare patients?
No, this is just Medicare fee-for-service, because that's why FQHCs and rural health centers can't participate, different model. So just Medicare fee-for-service that they're trying to get into a different track.
Okay, the next question, there's going to be some variance in our answer here, just to kind of forewarn you. If you have a multi-specialty group that has 40 primary care providers that work at any of their 12 branches, do they need to complete one application or 12 applications? Now, it could be somewhere, my guess is somewhere between 1 and 12, and here's why we say that. Again, go back to where we say brick and mortar. Now, if you have a provider, see, this is where it gets really complex. When you got the providers that travel, especially when their travel doesn't overlap.
Well, what it is, what they said, they call these satellites, is in the proposed regs, they call them satellite operations. And so whether or not you have to register separately depends on whether the satellite maintains the same patient base as the big site. And so if you see your providers moving around, but their patients basically follow them wherever they see patients, then that's one unified group for practices if they're at the same practice site, and they can be considered a satellite of another site.
But then where this gets a little gray, and we're going to try to get clarification on this, is if you have a site where, let's say you've got 3 or 4 providers that always work out of that site, but then you have other providers that travel through that site, that's where we kind of got to get a little clarification. And it may come back to, and again, I'm not saying this is what it is, it may come back to maybe it's you kind of define stuff by what they determine to be their home site. We will get clarification, Dr. Davis, and I'll follow up with you. Is this basically for larger practice, or is it recommended for solo providers?
It can be a solo provider. Absolutely. Unlike Medicaid in the first year where you're linked to being a PCMH model and stuff, under Medicare, this is my thinking, but I think it's probably how they're looking at it. They probably want a blend. They want the large providers, the ACOs, because they want to hit the ground running. But the intent of these movement of payment forms is for everyone, including the individual providers. So if you're willing to commit to a PCMH-like model, they are going to be willing to have you. And my guess is when they do that sorting as to which practices they're going to take, a certain number of those, that's why they cap the ACO providers. And I think a certain number of those are going to be the smaller solo practitioners or 2 practitioners.
Are sample letters for practice clinical leader and system leadership available? We've not been able to find those yet. I was on the site yesterday looking for samples.
We'll look.
Yeah, I can't find them yet. Doesn't mean they haven't added them in the last day or 2. I share office space with a pediatrician. Can I be on the Medicare CPC Plus and she be on the Medicaid CPC Plus? Again, think practice level when it comes to Medicare.
Yeah, absolutely. You do not need to be part of the same program. And since the pediatrician isn't even eligible for Medicare, then you are absolutely fine by each doing a separate application, one for Medicare and one for Medicaid.
Next is the care plan and the psychological and behavioral data included in the 2015 CERT edition. Does your vendor have to offer you the care plan and the social behavior criteria in order to be 2015 certified? Now, if you look closely at the 2015 certification, there's kind of what they're calling a base or a core certification. And I'm going to tell you my interpretation is of the base or the core 2015 cert, not all of the functions that they're referring to here would be included if your EHR just stuck to the core. But there are those extended 2015 CERT criteria that your EHR can provide. They don't necessarily have to, but they can. But by getting a letter from your HIT vendor, if you're track 2, if they write and submit a letter, that vendor will then be required by CMS to sign a memorandum of understanding saying that they're going to support you and they're doing what they said they can do in that letter. Now, there could be an additional cost. Let's be honest. Your EHR vendor is probably going to have their hand out, but they will be bound by an MOU to do what they say they could do.
Yeah, and I would say the care plan is getting to be a pretty standard addition as you move ahead to stage 3. The psychosocial, I want to look at a little bit more carefully to see what it is that CMS is wanting in that, and then we can give you a better idea of what we're seeing with the vendors.
Is it more advantageous to register for the Medicare CPC Plus or the Medicaid CPC? And I'm going to say in some cases yes, in some cases no, and it really depends at the practice.
Yeah, it depends on if you're eligible for both. If you're eligible for both, I would look at it carefully depending on your patient mix and, as I said, this financial requirements. If you're a solo practitioner or a solo site, you don't get into quite the, the horrible, how should you do it type of thing to segregate funds and stuff if you're a larger organization. If you're just a discrete one site organization, I would say the benefits are probably pretty evenly divided, but the larger you get, the more difficult it's going to be to manage the Medicare side. Obviously, the benefits can be great, but recognize there's going to be a whole lot of management besides the clinical behind the scenes on that.
Next question is with regards to the Patient and Family Advisory Council, are there HIPAA concerns? And you know what, there very well could be, but really what the expectation there is in generalities, from a patient's perspective, what's sticking and what really is not, they don't find engaging or really doesn't help them, in their opinion, get better or make them want to be engaged.
Yeah, and it's stuff like, think of it in terms of patient diabetic education programs. Obviously, anybody who comes into the program is going to be somewhat of a telling incident. Everybody's going to know that everyone in that room has diabetes, but that doesn't mean that it's necessarily a HIPAA breach. And the same thing's true in this patient care. You just have to be careful how you manage that so you do not get into any HIPAA violations. And that's actually an excellent point.
Absolutely.
So we'll talk about that as that program gets up.
If you are in an ACO, can you participate in the program? Yes and no.
Yes, you can absolutely participate if you're ACO on either Medicare or Medicaid side. So if you're part of ACO, it may have, as you said, slightly different payout to you, but the actual underlying structure, you're absolutely fine, and to a certain extent, you're given preferential treatment.
Yeah, there's some language in there about it being if you're in a next gen.
Yeah, well, the next gen. If I'm talking about Medicare shared savings,
right,
and not next gen or the newer models. I'm talking about shared savings that most of you are in.
All right, I'm going to read this question as it was submitted. This program is laborious. Expects the bonus payments and monthly payments to be used for the development of programs. So after all this hard work, extra hours spent, getting staff burnout, how does the practice bottom line improve? And I come into these programs wearing my rose-colored glasses. Here's my take on it. For one, that middle bucket, that is new dollars. Those are not dollars that you need to budget and follow through. Those are a performance bonus. That first bucket, you're right, that those dollars have to be expended. And yes, it is laborious to track those through. But think of it this way. If you can shave off some of the low-level visits that those patients that kind of come in for something that maybe could be addressed in one of these other care management programs, then that provider, that physician in your group can focus on those higher level needs. So it could in fact result in more dollars by your provider and other members of your care team operating at the absolute top of their certification.
I would say the two biggest areas you could use your funding is for increased staffing to allow you to be more creative, do better care management, transitional care management, home health visits. And the second area is increased IT functionality, because a lot of vendors, as you get into these more sophisticated areas, as we said, may have increased licensing requirements if there's a new module or something.
Yeah, and think of a medical assistant or nurse or a mid-level provider that really is focused on phone calls. I hate to say phone calls, but those phone calls to patients or that outreach portion of care management. So, all right, next one. Since commercial payers are also going to be part of CPC Plus, will those payers also include Medicare Advantage lives or just non-Medicare lives?
You know, I'm going to guess that they can include anything they want because they're considered commercial payers. The fact that they manage some of the Medicare payments, Medicare considers them in a different bucket from straight fee for service. So I would see no reason why they could not. I didn't see anything to show that they were prohibited from counting those.
I just checked. That's our last question. This has been recorded. We're going to post it. If we didn't answer your question, send us an email. We're going to send you some handouts. Again, they were available for download, but we're going to send them to you. And what we will include that I didn't include in the handouts is a copy of the CliniSync Global Letter of Support. We'll make sure everyone gets a copy of that as well. There's a chance we may do some follow-up webinars as more information becomes available. But if you have specific questions or you want some assistance evaluating your specific organization, we'd be more than happy to help you. Give us a call. Thank you very much.
Thanks all. Have a good evening.